How's everyone doing today? My name is Bridget Lake. I'm president of the Oviedo Winter Springs Regional Chamber of Commerce. We are here to serve as a platform for enhancing business and community interests in our region. And most importantly, we are a resource for your business, providing education, advocacy, and connections. Welcome to the Health Connections series presented by AdventHealth. This is our fourth of 6 Health Connections series. This series will focus on the health and well-being of our community by providing options to help reduce fears, manage stress, and provide tools and techniques to cope in this challenging time. Now, today's topic is Gerd, which stands for Gastroesophageal reflux disease. Also speaking about Barrett's esophagus and the risk for esophageal cancer. If you have any questions, make sure that you type them in the chat box. Our expert, Dr. K, who is with us today, will answer any of those at the end of the program. Now, let us give a huge thank you to today's sponsor, which is AdventHealth. AdventHealth has a complete care network in Seminole County, from 24/7 emergency care here in Oviedo to the whole person health and wellness in Altamont Springs and Winter Park. They have your whole family covered. Now, this month is Esophageal Awareness Month, and AdventHealth is at the forefront of advancement for complex disease care across Central Florida. The Digestive Health and Surgery Institute is home to the largest interventional endoscopy center in the U.S. and holds multiple accreditations across various subspecialty programs, offering world-class care close to home to help your family feel whole. One of the ways AdventHealth helps you feel whole is by diagnosing and treating unresolved heartburn. Over-the-counter drugs can only mask these symptoms. If left untreated, stomach acid can damage the lining of your esophagus, leading to permanent damage or even cancer. Trust the nationally recognized digestive health and cancer experts at AdventHealth to help you beat the heat of heartburn, or learn more at stopthereflux.com. Now, I really want to welcome today's featured speaker, Dr. K. He is a board-certified gastroenterologist with fellowships in interventional endoscopy and gastroenterology. He completed his residency in internal medicine at Maimonides Medical Center, Albert Einstein College of Medicine in New York. Dr. K has a special interest in endoscopic innovation and resection, and served as a key clinical facility member at Creighton University in Arizona and Coney Island Hospital in New York. He is proficient in English, Farsi, Russian, Hindi, Gujarati, and Marathi, which is way more languages than I can almost even pronounce. So thank you so much for coming here today, Dr. K. I hear you have a great presentation for us. Are you able to share your screen at this moment?
This one? I believe I am. Can you hear me?
Yes, thank you so much. Perfectly.
All right. Thank you, Bridget, for that kind introduction. And thank you, everyone, for taking the time on what I'm sure is a busy Friday morning. Thanks, Advent, for the opportunity, of course, to come out and speak about a topic that is quite dear to us, and a very preventable disease that we're able to help the community with. So without ado, I'll start off with the brief presentation and then take any questions that you may have. So our talk today is about gastroesophageal reflux disease, Barrett's esophagus, and the risk for esophageal cancer. And we chose to address a few questions, and we'll start off with what really is gastroesophageal reflux disease, what causes GERD, and what are the typical symptoms that you would present with, what the complications of untreated GERD are, and do we need to be screened for Barrett's esophagus, which is a precancerous condition that we'll talk about. how can early esophageal cancer be diagnosed and treated, and how do you treat uncomplicated GERD and its complications? So, gastroesophageal reflux disease in general is a condition that can be physiological, and by that I mean normal. So if it is postprandial after a large meal, usually short-lived, and rarely occurs during sleep, that might fall within the spectrum of what we consider otherwise normal reflux of acid. It's when it becomes persistent and causes injury to the inner lining of the esophagus that we start to get concerned about it and the risk of progression. And this type of reflux typically occurs at night. Now, it's interesting to note, and there have been several population studies that have looked at this. On an average, it affects about 20% of the Western Hemisphere, which really, if you think about it, is quite a sizable patient population. Now, just to go over the anatomy of what the upper digestive system normally looks like, I am not sure if you're able to see the pointer or not, but this tube here is the esophagus, and the esophagus conducts food once you've chewed it and swallowed it, propagates it all the way down past an important sphincter called the lower esophageal sphincter into the stomach, where it mixes with the acid and then aids with digestion. Now, the stomach normally produces acid, and acid is a good thing. It helps, like we'll discuss in a bit, prevent infections. It helps with digestion of food. And it's only when this muscle here turns weak for several reasons that we'll discuss, or if there is an increase in the level of acid production, that it starts to reflux up into the esophagus, the inner lining of which is not normally able to withstand the acidic environment and tends to get hurt. So what are the causes of GERD really? And just to briefly summarize, there are several hormones that we normally produce that will control a certain pump in the stomach that produces acid. Now, it can be triggered by several factors and chemicals. It can be triggered by food, can be triggered by stress. And what it all culminates in is an increase in the acid production within the stomach. And again, like this little cartoon here will show, it's when the acid refluxes into the esophagus that we experience what we call gastroesophageal reflux. Now, what are the symptoms, and what would prompt someone to think about abnormal acid reflux? And the majority of symptoms present, or the majority of patients present with esophageal symptoms. The most classic symptom here is heartburn, and this is the typical sensation of burning in the retrosternal or the chest area that may or may not happen after meals. Patients also will complain of regurgitation. Other less common symptoms are dysphagia or trouble with swallowing. Chest pain, interestingly, one of the most common causes that patients present to hospitals for that is not heart-related is reflux causing chest pain. Other symptoms are water brash. This is the sour taste in the mouth that you can occasionally have. A globus sensation, that's the sensation of something getting caught in the throat. And odynophagia, which is a painful swallowing. In addition to that, there are a minority of patients that will present with what we term extraesophageal symptoms, which truly don't come from irritation of the esophagus itself, but from traveling of the acid into the airways. And a common one there is chronic cough. So patients would present with this cough that is relentless, is not being treated with standard over-the-counters. And one of the common causes of that is just a silent reflux of acid. Hoarseness in the voice, wheezing, and occasionally nausea. So if we look at this cartoon here and the anatomy of the upper digestive airway, what we see is this area is the esophagus. And conceptually, as the acid refluxes into the esophagus and sits at the back of the throat, it can also travel up into the nasal airways and cause sinusitis. Some of the acid can travel into the larynx and subsequently into the lungs and cause the chronic cough that we had just discussed. If the irritation is enough, it would eventually injure the inside of the upper airway and cause it to narrow. And it occasionally causes dental caries as well. Now, what are the complications of long-term reflux of acid into the esophagus? And truly, why is this something that we should be bothered with? Esophagitis is the first that we'll talk about. That is an endoscopic picture of the inside of the esophagus. This here is what we call the Z line, or the change between the normal gastric inner lining and the esophageal inner lining. And what you're seeing here are linear areas of redness or ulceration. So this is the very early form of injury that occurs after acid refluxes into the esophagus that will eventually worsen and lead to a more confluent type injury. Eventually starts to get circumferential and can be quite severe and result in persistent epigastric or upper abdominal and retrosternal or chest discomfort. Now, as the acid continues to injure the esophagus, the inner lining of the esophagus starts to erode, ulcerate, and scar down. And when that happens, the lumen of the esophagus tends to narrow down. And this is an X-ray of a patient with a stricture in the lower part of the esophagus. As you can see, up here is a normal diameter or a caliber of the esophagus. And here you have a significant narrowing. And the way this presents is with difficulty swallowing. Here's another stricture that's higher up in the esophagus. And this is what it looks like on endoscopy. So instead of seeing a nice open lumen that would otherwise conduct food into the stomach, what you're seeing is a significant narrowing in this area that, of course, can have food stuck in it over a period of time, result in dysphagia and progressive trouble with swallowing. Now, as the disease progresses, we start to develop a persistent change in the inner lining of the esophagus. And this here is what the pathology typically looks like, where you have expansion of certain layers in an effort really to protect the inner lining of the esophagus and turn or metamorphosize in a way into a lining that is naturally protective, like that of the stomach. And as that change occurs, it starts to get pre-neoplastic or precancerous, and it's what we call Barrett's esophagus. Here you see these little cells that produce mucus that normally is produced in the stomach, and it's the lower lining of the esophagus that's changing to protect the esophagus from this long-standing acid exposure. This is how it looks like on endoscopy, where you're seeing the salmon-colored persistent change in the inner lining of the lower part of the esophagus. And that's a cartoon showing what that abnormality looks like. So this here is the stomach. This is what normal esophagus looks like. And this Z line normally is located down here. And this columnar, or the abnormal change that we were discussing, is this salmon-colored change down here. And this is truly what we worry about as physicians and endoscopists, because it's this change that carries with it the potential to turn cancerous. Now, there's normally about 5 steps that you go through before you turn into a cancer. from a normal lining, the lining changes to what we call Barrett's esophagus, and this is something that endoscopy can pick up. It'll then move on to low-grade dysplasia, subsequently high-grade dysplasia, and then a cancer. So there we go. Yeah. Now, this is what the endoscopy of a normal early cancer in the esophagus looks like. What you're seeing here is a very mild bulge that's sometimes difficult to visualize even on white light endoscopy, and requires special light filters and staining that will be done by your gastroenterologist. And it can be quite subtle, really, in its very early form. This is what the cancer looks like as it advances. And here what you're seeing is a circumferential or a round ulcerating tumor in the lower esophagus. And unfortunately, it's not until you get to this stage that you really start to have symptoms of bleeding, iron deficiency, unexplained weight loss, and it truly becomes symptomatic only later in its course. And here is a picture of a large, at this stage, it's really unresectable cancer in the lower esophagus. This is a mass that is nearly obstructing the outlet of the esophagus. And these type of patients usually would present with just an inability to tolerate an oral diet and weight loss. Now, what can we do to prevent this? And the question that frequently will arise is, do I need to be screened for this pre-malignant condition? And we fall back to the American College of Gastroenterology that's looked at retroactive data, millions of patients. And what we've realized is that there is a benefit to screening patients that are at risk of developing cancer in the esophagus. And those patients are patients that have had reflux for approximately 5 years or more, and have at least one of the following: are over the age of 50, males, because males are more likely to develop cancer, are white, have the presence of a hiatal hernia or carry a diagnosis thereof, are generally overweight or abdominal obesity, have nocturnal reflux. That's an important symptom to look for, reflux at night, are otherwise smoking or chewing tobacco, and have a first-degree relative that has Barrett's esophagus or cancer of the esophagus, because that subset of patients is more likely to develop esophageal cancer than others. Now, once your doctor has identified the presence of gastroesophageal reflux, what can we do about it? Now, normally what we would recommend is that we start with basic lifestyle modifications. And by those, I mean just reducing the consumption of caffeine, caffeinated products beyond midday is what we recommend. Avoidance of acidic foods like citrus containing foods, or tomatoes is another common offender there, or foods that have acidic potential to them, like carbonated beverages. To avoid eating or drinking within 3 hours of going to bed. That usually helps with nighttime symptoms. And of course, this is something you hear from your doctors time and again, is to avoid smoking tobacco and reduce alcohol consumption as possible. Now, if despite this, we're not able to control the GERD, we then move on to medicines, and we'll discuss some about this in a minute. But the mainstay here is a class of drugs that we call the proton pump inhibitors. And what they do is they essentially reduce the burden of acid in the stomach, and that translates to a reduction in overall reflux into the esophagus. Now, for patients that are not responding to either of these two, we then move on to anti-reflux procedures that can be done endoscopically, and we do those here at our center. We have the transoral incisionless fundoplication that we'll talk about, and the anti-reflux mucosotomy. There's also operations that we offer patients that are aimed again at either strengthening that valve that prevents the reflux of acid, or altering the anatomy in a way that reduces the acid exposure. This is a brief cartoon again of the spectrum of patients, which is the bulk that will respond to lifestyle changes and pharmaceuticals like proton pump inhibitors. Approximately 30 to 35% of patients will not and will require some form of definitive management. We try to intervene minimally invasively when possible through endoscopic measures. And for patients that either choose to have an operation to begin with, or that will fail endoscopic measures, we then move on to conventional surgery. And this is in about, close to 0.5% of the overall Gerd spectrum. Now, the proton pump inhibitors that we had spoken about, when they originally were discovered, were this wonderful class of medicines that gastroenterologists around the country were broadly using in patients. And it is recently that we're starting to learn about the downside of patients using these medicines in the long term. And there is anecdotal data that connects long-term PPI use with non-vascular dementia. It increases the risk of stroke. It's associated with cardiovascular disease, the presence of polyps in the stomach, an increase in infections that can be quite severe, iron and vitamin B12 deficiencies, and in particular osteoporosis when used in women over the age of 50. So to summarize, the medicines that we've traditionally been having patients take for years on end, we're now learning are not the holy grail, if you will, of treating GERD or acid-related symptoms, and that there is a significant downside to long-standing use of proton pump inhibitors. Now, just briefly, anti-reflux operations, very efficacious and work very well. The most common one in the United States is the Nissen's fundoplication, which is where the upper part of the stomach is really wrapped around the esophagus and sutured in place, altering the anatomy and reinforcing the valve that normally keeps the acid in the stomach and doesn't allow it to reflux up. Has very credible and long-standing data supporting the operation. And amongst the patients that require surgery, this is the most common one. In patients that are obese and otherwise are refractory, this is a diverting operation that really excludes almost the entire acid-creating apparatus in the stomach and creates a little pouch that helps both with weight loss and acid exposure prevention. And this was the trans-oral incisionless fundoplication that we were discussing. This is a minimally invasive procedure done via an endoscope as a day procedure. Patients come into our endo center, we do an endoscopy. We essentially, through the mouth under anesthesia, pass a device that allows us to recreate or re-strengthen the valve in the lower esophagus that keeps the acid down in the stomach. Also has robust data supporting its use and is a good alternative to a more invasive operation in patients that will fit the bill. Now, the whole purpose of screening for the pre-malignant condition is that we can now do something to prevent its progression into frank cancer, or when we do find early cancers, that we're able to treat them endoscopically through the mouth, usually as a same-day procedure. And these patients don't normally require the traditional operation that involves resecting the upper stomach and the lower part of the esophagus. Now, this is an example of what is called endoscopic mucosal resection, again done through the mouth as a day procedure. Here, the endoscopist is placing little rubber bands around what is dysplastic tissue or immediately precancerous tissue. With an electric snare being placed around it, you resect it, creating an ulcer, and it's subsequently sent to a pathologist who stages it, looks at it, and tells us whether or not we should continue, and whether it's a cure or not. In this case, what we have is an early cancer. And what the endoscopist here has done is make markings around it, make an injection of a particular substance right under it that safely raises it off the muscle layer, and then literally fillet it off with a knife that allows us to resect this lesion en bloc or in one piece. And in the vast majority of cases for superficial cancers is considered a cure. And it's not something that's offered at most centers. We offer it here at the Center for Interventional Endoscopy, and it's great, the results that we have in preventing these patients from moving on to standard morbid operations. Now, in addition to resection, we also have methods of burning the inside of the dysplastic Barrett's and preventing it from progressing. To mention a few commonly used ones, is radio frequency ablation, where radio waves are used to burn the inner lining. Argon plasma coagulators to burn shorter segments of Barrett's, and cryotherapy that usually uses carbon dioxide, liquid carbon dioxide to freeze, if you will, the inner lining of the esophagus. Now, I'll conclude by looking at this graph here that truly is encouraging. We have tried to increase public awareness of the presence of Gerd and how it can progress to dysplasia and cancer, and what the role of an endoscopy is in being able to prevent truly progression into a cancer, and in many cases treat the cancer. And what you're seeing here is this dark line that despite being a population that is at high risk, we've managed to put a plateau in the incidence and mortality from esophageal cancer since we started screening for Barrett's. And I suspect as we broaden public awareness and improve our options made available to patients, that I only anticipate that this will decrease with time. And the one take-home message from this talk would be that Barrett's esophagus and esophageal cancer can truly be a preventable disease if the patients at risk are identified in time and screened and treated appropriately. So thank you, everyone, for taking the time again, and I'm happy to take any questions.
Well, thank you, Dr. K. That was very informative. I feel like I went through a medical class right there, just with all the images and the pictures and a lot of great information. Now, you mentioned in the very beginning that GERD affects about 20% of the Western Hemisphere. Is there something in our diet that is different from other areas of the world that it's better or worse than other parts? Can you get a little bit into that?
Thank you, Bridget. That's an excellent question. What we notice is that patients that immigrate to the United States, and there was a great study recently published that looked at how a Western diet affects immigrants. And what we noticed is that patients with an otherwise relatively lower incidence of Barrett's esophagus and esophageal cancer that immigrate to the United States and are then adapting our diet here are starting to develop higher incidences of Barrett's and cancer. And so, in answer to your question, there are several things in our diet, particularly, just to name a few. We have a lot of highly processed fast foods out there that the carbonated beverages. A non-whole grain, which is the highly refined breads that we use. So there are several things that our population consumes a lot more of here that translates to that higher incidence. Having said that, I wouldn't implicate the diet alone. We know that there are certain racial backgrounds that will have a higher incidence of Barrett's overall. And it's the whiter, Caucasians tend to have more Barrett's in general, as do patients with obesity. And, here in the United States, obesity is truly I want to call it we're bordering on an epidemic, really, where a large percentage of our patients, as a result, of course, of that diet, are developing problems with weight that then translates to higher reflux rates.
Well, thank you for that. So you were talking about some foods to avoid, which I think was really interesting. Fast foods, carbonated drinks, etc. Are there any specific foods that may help prevent any type of gastro problems?
Bridget, it's in general, if you were to classify foods, there are foods that have lower pHs or high acidity that will cause immediate symptoms. And this is, your tomato type products, your citrus fruits, the grapefruit. And then there are foods that will promote acidity, like the carbonated beverages that we had spoken about. There are caffeine is a big implicator, and the way that coffee affects reflux is it truly loosens the valve, if you will, that keeps the acid at bay in the stomach, and it also will increase the acid thereof. Now, foods that generally would reduce acidity, we recommend fresh fruits and vegetables. We recommend whole grain foods. And while this is not evidence-based, we learn that indirectly in promoting healthy food habits and weight loss, that this translates to a reduction in overall acidity and reflux symptoms.
Great. Thank you for that. Let me ask you this, because you talked about some of the symptoms, and one of them happened to be chest pain, which I thought was interesting, because is there a difference between chest pain that you get from Gerd and maybe chest pain that you may get from something that's more serious, as something with your heart?
Right, Bridget. The caveat in this type of a situation is that chest pain is chest pain. And our general recommendation is that if and when it does occur, unless you've already been ruled out for an underlying heart problem, that you present to have your heart checked, because unquestionably heart problems are something that need to be intervened on in an urgent basis. Now, having said that, there could be differences in the type of chest pain that patients would experience, and it has to do a lot with the underlying risk factors. So patients that have had long-standing symptoms of reflux, particularly at night, and then tend to have discomfort that is around the breastbone or the sternal area, are typically the patients that would have a reflux type of pain. That pain is not associated with exercise in any way, as opposed to the heart pain that you experience more when you exercise. It's called stable angina or exertional type pain. So there are some nuances and differences, but the general message is that when you do have chest pain, that the best strategy is to seek medical attention and have them rule out a heart issue first and subsequently have an endoscopy done.
I would definitely follow that advice for sure. You had also talked about studies and screenings, and I know a lot of hospitals do this. Does AdventHealth have any type of screening for people that may be predisposed to this, to Gerd or Barrett's disease?
Certainly, Bridget. We have a large network of gastroenterologists and a motility program. And our generalists are very good with identifying patients that are at risk and screening them for the presence of Barrett's and/or dysplasia. It's when the general gastroenterologists find that dysplasia that we then will receive them at our center here for interventional endoscopy, where we specialize in treating the dysplastic esophagus or in doing the endoscopic anti-reflux procedures if and when they're indicated. But the cornerstone is really to spread public awareness, because ultimately it is the patients that are at home silently tolerating the reflux with over-the-counter medicines that are the patients that are truly at risk for developing the spontaneous cancer that is frequently untreatable by the time we get them in.
And that does have a really good point there, because I know I've only had heartburn probably 2 or 3 times, and it was when I immediately laid down after a meal and I was like, what is that? And it's got this weird burning to it that is very unusual if you've never felt it before. Now, when it comes to, and this is something that not only and since I'm not going to go on WebMD, I have a doctor right in front of me, I'm going to ask you this question. So when it comes to after I eat, and this is not just myself, but you see people cough a little bit more. I've noticed it when I eat faster. I tend to always be trying to clear my throat. Is this the pre-condition of what could happen with GERD, or is that something different?
Bridget, it's not uncommon to have a somewhat of an abnormal sensation in the back of the throat or the hypopharynx when eating meals that will otherwise promote reflux. Having said that, it is the atypical symptoms of reflux that we aim at identifying. Only because patients will frequently see generalists on the outside and get started on treatment for asthma and other conditions when the root of the problem truly is just benign reflux.
Mm-hmm. Okay. And we have one of our participants asking a follow-up question. What are the long-term effects of Tums for heartburn?
Well, in general, what we try to recommend is avoidance of over-the-counter medicines and to seek advice. But Tums is a generally very well tolerated drug that we would frequently prescribe to patients that will have the benign reflux that is postprandial and happens after eating an acid-provoking meal. So not something that is generally safe as long as it's used appropriately.
So I'm assuming you're suggesting don't use it every day? Or if you are using it every day, maybe you should.
If you require to use over-the-counter medicines on a daily basis or consistently to prevent GERD, then my suggestion, and if this is in particular happening for an extended period of time, my suggestion normally would be to see your gastroenterologist and get screened for Barrett's. And the reason for that is that over-the-counters will frequently mask long-standing effects of GERD. And so while it takes care of the symptoms, patients out there will frequently not seek medical advice and have underlying dysplasia and what have you. So in general, it's safe to use for symptom control, but if this has been going on for some time, my advice would be to see your gastroenterologist to ensure that you're not somebody that requires screening. And if you are, an endoscopy is nowadays extremely safe with our advances in anesthesia, day procedure, and the benefits by far outweigh the risks.
Well, thank you so much, Dr. K. We really appreciate you joining us. We want to thank AdventHealth for another educational and timely healthcare connections series segment. And I wish everyone a wonderful weekend. Happy Friday. Bye, everyone.
Thank you.